Hello, and welcome to another live broadcast with MedStar Health. My name is Karen Zingle, and I'm joined today by foot and ankle surgeon, Dr. Jacob Wisbeck, and sports medicine surgeon, Dr. Richard Levine. Today, we're going to be talking about the sports injuries that can occur on turf and grass. Which surface is safer? What are common injuries for feet, ankles, and the kinetic chain? Can they be prevented, and how are they treated? So if you're a field athlete who wants to safely continue playing, then stick around, share this broadcast with your friends, and ask your questions for Dr. Levine and Dr. Wisbeck in the comments below. So Dr. Levine, Dr. Wisbeck, thank you for joining us. Before we begin our discussion, can you tell our viewers a little bit about yourself and your specialties?
Okay, I'll go.
Hi, go ahead, Rich.
Oh, sure. Well, Karen, thanks for having us on this. I'm a rookie at this event on Facebook, so please bear with me. So I'm originally from New York, and I moved down to Baltimore about 20 years ago. I did my training up in New York, started at Cornell University, then did State University in New York, followed by some training at Rutgers, and then down to Baltimore to do a fellowship at Union Memorial, which is part of MedStar in sports medicine and arthroscopy. So my practice is focused mostly on sports medicine. I see patients in the office in Bel Air, Timonium, and now our new office in Annapolis. I mostly do shoulder and knee surgery, but I'm also involved with a lot of team coverage. This is my 19th season with the Baltimore Ravens as one of the team physicians. 10 plus years at Towson University, 20 years with the Baltimore Blast, and 20 years with Goucher. So sports medicine is my focus, and I'm really happy to be here.
And thank you for joining us. You're going to do great. Dr. Wisbeck.
Hello, everyone. Jake Wisbeck. I am an orthopedic surgeon that specializes in essentially everything below the knee, lower extremity, and foot and ankle. My focus is primarily sports-related injuries and trauma. I also do reconstruction as well. So there are a lot of injuries that can occur in the lower extremity and a lot of bones. It's actually quite complex. There are times that you're fixing things, you're not fixing things. And I really do believe that a good thorough evaluation and making sure that surgery is absolutely needed versus maybe trying to get things done without surgery is a thought process that's taken seriously in my practice. And I focus on that. And if we can manage it without anything invasive, we do. If not, we'll go through all the details. So that's an important philosophy of mine, is doing the best you can not to do too much. That being said, I manage a lot of athletes. Unlike Dr. Levine, who's on the field a lot, I kind of get them secondhand, but I am involved in the professional teams with our sports docs. I'm also involved in almost all the colleges around at some level. And so a lot of experience managing athletes, athletic problems, getting people back to play, and the trauma that comes along with that. So.
Well, thank you very much. Thank you both. So you mentioned the locations. Dr. Wisbeck, I believe you're joining us from the Ellicott City location, and Dr. Levine, you're in the new location in Annapolis. Dr. Levine, can you tell us a little bit about that site and what it means to bring your expertise into the community?
Yeah, absolutely. So this is a new site for us. Traditionally, Dr. Wisbeck and I are based out of Union Memorial, which has been very much a destination hospital of orthopedic expertise over the past 20 years. And we're kind of excited to start shifting a little bit and bringing that out into the community and moving to new areas. So this Annapolis office is a relatively new area for us to actually be seeing patients, although a lot of our patients certainly come from this region and usually travel to us. So a brand new facility. It's part of the urgent care on General's Highway. And we're expanding here and looking to grow the footprint.
Thank you so much. Yeah. Really appreciate that. That's very exciting. Dr. Wisbeck, anything to add to that or to talk about with the Ellicott City location?
Well, absolutely. So Dr. Levine mentioned Union Memorial. So I also see patients there. We have a very nice Timonium office with a surgery center attached to it that we both see patients at as well. Ellicott City has become a very prominent office for me, reaching out to Howard County, Western Maryland, and DC. And I'm also seeing patients with Dr. Levine in Annapolis, which again is a new venture. That being said, I've been seeing patients in Anne Arundel County at our Wall Chapel office for years now. So again, expanding that, and we have hopes of growing, revamping facilities down in Annapolis. And I really think it's going to be a great experience down there once we really get going and get seated.
That's wonderful. So yeah, it sounds like we are in multiple areas in the in multiple communities in the area. So that's a real benefit for our patients because they can see us in lots of different places, and exciting to hear there's more to come. So let's get into some questions about our sports injury topic. Thank you so much for the background about yourselves and our orthopedic locations. So let's talk about moving from the clinic to the field. Both of you are experts in different types of injuries, some that can occur in the sports field. What is your opinion on grass versus turf fields and the effects they can have on sports injuries in general? Dr. Levine, why don't we start with you?
Sure. Well, interesting that there's a lot of research that's been done over the past 15 years or so about grass versus turf and what are the injury rates. But what we need to understand is that the turf has also gone through an evolution. So the initial AstroTurf was a cement slab with some very short grass type of plastic almost that sits on it that was a very hard surface. And that evolved into putting some sand under it. And now we're into the third and fourth generation turf fields that most people are familiar with, which have that recycled rubber that almost functions as if it's dirt between the longer strands of plastic that reproduces more of a grass feel. So a lot of the early studies looking at are there increased injuries are hard to really interpret. So we're looking at these newer studies that are being run. And I think this really got the focus of a lot of people when there was an NFL study, I think in 2018, that was showing up to 16% increase in lower extremity injuries. But there have been multiple studies over the years, and the bottom line is it's pretty controversial. So for every study that you can come up with that says there's an increased rate of injury, I can come up with another one that says there's not. I think overall, looking at the literature myself, my feeling is there probably is an increased risk of lower extremity injury, but it's not worked out yet. And Dr. Wisbeck can talk a bit about how the foot interacts with the turf, but the cleat itself is a lot to do with it. So there have been studies looking at some of those older cleats, if you remember, that had the side spikes sticking out. And that made you grip really hard, and that had a high injury rate. So those are gone for the most part. If you really look around, we don't use those on turf anymore. So it's not only the turf field, but it's also the shoe wear and how that interacts with the field, even up to, is it summertime when the turf is dry versus wet or cold, and multiple different studies showing a lot of things. So my gut feeling, and I think the literature really supports that, yes, there is an increased injury rate, but we haven't worked it out yet. So as of now, I wouldn't say that you shouldn't play on turf, but just be aware that maybe you can modify some things by getting the right footwear for the right turf field.
Thank you very much. Dr. Wisbeck, you want to add on to that?
Sure. I think Rich did a great job of summarizing it. The bottom line is we just don't know. There's some literature out there that suggests that there's more ankle sprains or twisting mechanisms just because of the grip, as he was saying, that you get on the turf field versus maybe a grass field where you're sliding a little bit more as opposed to grasping and twisting. And a lot of foot and ankle injuries come with a twisting mechanism. That being said, there's also less incidence of the bigger, higher ankle sprains. At least that's what's suggested. So I do agree it's controversial. If you really think about these turf fields, they wear and tear as well. So a brand new one that's put down that's got a bit more of a fluff to it or cushiony, it's more like grass, over 5-10 years gets matted down and becomes more like that first generation turf from a long time ago, where it truly feels like concrete when you're running on it. So I think there's way too many variables to make an absolute judgment on it. We also know that the turf fields come with less potholes and divots and holes in the field where you plant your foot in a pothole, and we all know ankle sprains. We twist our foot sprains, fractures. You don't have that with turf. So again, there's benefits to maybe turf compared to a non-manicured field, or the old fields we used to play on in the counties, and that had like potholes and pods of grass and dirt holes, as opposed to, let's say, a manicured fairway type grass, or that the professionals play on or college teams play on. So understand that those are the comparisons that are being made, and it's hard to really kind of go against the turf fields when places are using them. They're able to get games done. They're able to get games done in the rain. They can have many more games than a turf field or a grass field could tolerate. So there are lots of benefits, and I think it's a gray area about the injuries, and I would not be worried about playing on or having my child playing on a turf field. I don't see that as a big negative compared to, let's say, a grass field.
Yeah.
Okay.
And for those viewers out there that really want to take a close look at this, there's a lot of studies out there that you can find just by going online. One of our partners, Rich Hinton, who has got his master's in public health, did a great study looking at all the NCAA data for football players over a 10-year period. And his information is out there looking at what are the injury rates. And believe it or not, they found that some injuries, like a PCL tear, which is by far not common, is much more likely on a turf field. But when you look at the ones that everybody's worried about, your ACL tears or some of your ankle injuries, it didn't pan out completely on the D1 football players. But when you stratified out some of the D2, D3 players that may not have as much of the newer fields, the newer turfs, there actually was an increased risk of having things like ACL tears. So the literature's out there, and it's really not that complicated to review. So you shouldn't be afraid to pull up some of these studies and read through them, because they're pretty well explained. And then be informed and help yourself make your own decision about it as well.
Thank you both very much. That was extremely helpful. Let's talk about those types of injuries that athletes can face. Dr. Wisbeck, let's start from the ground up. What are some of the foot and ankle injuries that athletes face?
Yeah, as mentioned earlier, the ankle and the foot is a very complex kind of anatomic joint, at least the ankle. It's not just a hinge joint up and down. There's a rotational component to it. The foot, 28 bones, 33 joints, and all are at risk for injury. The most common injuries that people will have are sprains. By definition, a sprain is an injury of a ligament. A ligament attaches two bones together. Whether that sprain is a partial tear, complete tear, it still falls under those sprains. So you can have different degrees of sprains. Some people just tweak their ankle, can keep playing through it, never have a day off. And there are other people that need to be non-weight bearing in a boot several months to recover. And people with some sprains even need surgery. Tendon injuries, particularly the weekend warriors, people my age, maybe a little younger, a little older. Achilles tendon ruptures, probably the most common and most famous of tendon injuries in the foot and ankle. But all tendons are at risk. Fractures, again, ankle fractures, very, very common, most likely from a twisting mechanism, tackles in football. You can have high ankle sprain injuries with the fractures. Foot fractures are also very, very common. Metatarsal fractures, which are often treated without surgery. Certain metatarsals, particularly the fifth metatarsal, which is the one on the lateral aspect of the foot, the treatment is really based on what part of that metatarsal has been fractured. So again, having that ability to get evaluated and understand the exact injury and what's going on may lead to very different treatment processes. And then there's the overuse stuff. Again, weekend warrior stuff, but even young, healthy individuals that are active athletes, college professional athletes, can get overuse injuries, whether that's stress fractures, stress reactions, by definition, just a little bit different in the sense that maybe it's a bone that's very painful, secondary to overuse, but hasn't quite got a fracture. Then there are the tendinitises or the arthritises, and The itis means inflammation, so all these things could be inflamed from the overuse. Oftentimes it's a rest or an adjustment. It could be as simple as a shoe wear adjustment. It could be an activity modification, but sometimes requires, again, immobilization and sometimes even surgery. So all these things come into play. The foot and ankle, really, it's not just the foot. We put weight on it every other step. And again, very complex in terms of its anatomy. And so, a lot of things can happen in the athlete. Again, it's kind of common. So it's not like a rare situation.
Thank you very much. What are some of the symptoms that someone would experience if they did have some kind of foot or ankle injury that occurred to them? I imagine pain would be one.
Of course. So, the acute traumas, pain is obviously what everyone is getting that makes them concerned. Swelling can also be an issue, and the swelling may be something that's just coming about without an acute injury or onset, and just worsens it over time. The inability to walk on your foot or to bear weight on your foot is an indicator that something significant really is going on. But even if you can walk on it, having that discomfort or pain, maybe choosing not to continue to play or getting it evaluated is the best move before maybe something worse or something gets either re-injured or worsened in terms of its injury. If you plow through it, the no pain, no gain idea is historically been seen as a bravado, but nowadays we have some really, not just the finely tuned athletes, not just the ones that are doing it professionally or in college and high school, even in youth sports, people are spending 5-7 days a week, sometimes multiple times a day training. These things can pop up, and ignoring pain is not a great idea. Getting evaluated is a much better idea, at least to make sure that if you're ignoring it, you're not causing a bigger problem.
Yep, thank you very much. And speaking of those evaluations, can you talk about what is the diagnosis process when someone does experience those symptoms and seeks help from a physician?
Absolutely. So, in my opinion, an adequate exam comes with a good physical exam. Again, 28 bones, 33 joints with your ankle, palpation of essentially each one of those, making sure where you're hurting and what you're hurting, what is hurting, I should say, is important. A radiographic exam, meaning getting x-rays and weight-bearing x-rays, if you could tolerate it. Obviously, with an acute injury, broken ankle, we're not getting weight-bearing images. But weight-bearing x-rays are important. It gives us an understanding of alignment. It gives us an understanding of cartilage health, joint space, whether there's an arthritic process or not. And then figuring out management. Do you require advanced imaging? Do you require an MRI, a CT scan? Or do we just give this some time first before we start looking for some unusual diagnoses? So the exam should be very thorough. It's consistent. We're looking at palpation of pain. We're looking at vasculature, whether you have pulses, good perfusion, whether your nerves are working, whether your tendons are firing. If your strength is good, sometimes you can have a neurologic stretch or injury and you get some weakness. So it's not truly a weakness in muscle, it's actually a nerve issue. So those details come out with a good, thorough exam. And then making decisions as to whether or not you need advanced imaging and what the next steps are come from that.
Yeah, that sounds very thorough. Thank you so much. What about the treatment? So you mentioned earlier, maybe a orthotic in your shoe, potentially surgery. What are some of the treatment options that we have available for our patients?
Sure. I mean, treatments are obviously diagnosis based.
Right.
And so you can have, I explain it to people as a scale of immobilization, right? You can start out, the simplest thing you can do is not doing the things that hurt, just activity modification, possibly adjustment of a shoe, then maybe an arch support orthotic if it's something that's amenable to that. a tendonitis or some plantar fasciitis arch pain, or maybe a stress reaction or something like that where the bone's hurting and needs some unloading. And then there's bracing. You can use ankle braces to support an ankle, maybe with a mild sprain or just some nuisance pain or some mild tendonitis, and maybe even keep playing with that brace. And then you get into the immobilization. Do you need a boot brace? Do you need to lock things down? Can you be weight bearing in a boot brace? Do you need to be on crutches and non-weight bearing? Rarely do I use casts in this world. We've grown past casts for the most part. There are some specific uses for that, but it's very rare that we would need a cast these days. But a boot, possibly with some immobilization, with non-weight bearing with crutches to get over the hump or let a fracture heal is a possibility. And then obviously, if indicated, surgery is an option. And surgery happens when things either aren't going well without surgery, or it's just indicated to do it because it's in the best interest of the injury or the patient to get the anatomy perfect again, or at least as close to perfect as possible, or it's most reliable to heal with a surgery. And those indications are discussed with the patient to make a plan to give them the best options.
Thank you very much. What you mentioned a couple things that sounded to me like some preventative measures, perhaps with the type of shoe that you wear, with orthotics. But can you talk about some preventative measures that we can consider before we step on the field, whether it be turf or grass? And is there any future prevention that we should be thinking about that is coming later in the future?
Yeah, I think that, for foot and ankle, shoe wear is important. It's something that's comfortable, that fits you. You don't just buy it because the other kid has it or the other guy has it, or, the shoe store told me that this was the one, particularly with runners. I think that the shoes are all built around a last and at the shoe companies. And if the last matches your foot, then maybe the shoes fit. If the last is not matching your foot, maybe that brand just isn't built for your foot. And the only way to know is to really trial and error and really take your time when you're buying your shoes, particularly for the runners. Athletes, if you're doing a lot of training on a hard turf and you're prone to having some foot pain, maybe training with a turf shoe instead of cleats is a good idea. For the weekend warriors, or really anybody, flexibility is a key issue. And the stretching that occurs, as we get busy in our lives, and we want to work out, maybe we have a half hour, 45 minutes to work out. We tend to spend maybe a minute or two stretching. We spend our 30 minutes working out to get our workout in. And if we even think about it while we're rushing to get back to work or pick up our kids, maybe we stretch a little bit afterwards. And that really needs to change, particularly for the folks going into the late 20s, 30s and beyond, because as we do get older, our bodies do get less flexible. And so staying flexible prevents some of the weekend warrior stuff, nuisance stuff, Achilles tendonitis, plantar fasciitis, many of the itises. And it's important to stay flexible in addition to working out. So recommendation would be to warm up, stretch out before, take a good bit of time, of several minutes, continue staying limber and stretched out throughout the workout, and then afterwards as well. And so those are the types of preventative measurements for the foot that will really go a long way to try and prevent particularly some of the overuse or as I said, weekend warrior stuff. You can use lace-up ankle braces. It's hard for me to tell people who've never had an injury that you need to use a brace to be preventative for twisting mechanisms, but I do know that many volleyball teams are using the active ankle as a preventative measure for landing on somebody's foot or landing on a ball and twisting their ankle. It's hard to say that it's absolutely recommended, but that's something that they're doing, and we'll see how that ends out. But a lace-up brace for somebody who's had a previous injury and doesn't want to have another one, they put it in their gym bag and they use it. I don't believe there's harm in that. So again, it's not something I would tell people to go out and do just to prevent injuries, but it is something that if you're an at-risk person or have had previous injuries, you may be able to prevent something in the future by doing that.
Those are great tips. Thank you very much. So let's move over to some other areas of your body for those of us that remember our anatomy classes. As the song says, the foot bone's connected to the knee bone's connected to the thigh bone. So there's obviously other ways that we can get injured because everything is really connected there. So Dr. Levine, can you talk about some of those other areas and other kinds of sports injuries that field athletes face, especially if they do some pivots, starting and stopping with their bodies? Can you talk about just the basic anatomy and talk about the types of injuries that someone could face?
Sure, absolutely. So, we're talking about lower extremity injuries, how your lower extremity, your foot, your ankle, your knee relate to the turf. So everybody knows the big thing that you're always worried about playing sports is, am I going to blow out my knee? Are my kids going to blow out their knee? And the knee is, for the most part, much less complex than some of the details in the foot and ankle, in that you can kind of divide it into the ligament injuries. That's the thing that nobody wants, tearing your ACL, anterior cruciate ligament. There are 4 major ligaments in the knee, but that's really the one to talk about because that's the one that's going to be the season ending, the career ending potentially, or the surgical problem. Other things in the knee, there's cartilage. Cartilage is like the gristle on a chicken bone. It's on the end of all of your joints. And as that wears out over the course of your life, that's what arthritis is. So we're worried about injuries there. And then there's a little pad between the bones called the meniscus, which is also cartilage. And you can get a tear in that. But for the most part, when people are concerned about, hey, what do I really want to prevent? I want to prevent that knee blowout or the tear to the ACL. So I have a little model here because everybody walks around with knee models, of course, everybody online. So I have a couple at home. So on this knee model, if you could see, I'll bring it up to the camera here. There's your ACL. It's this little thing right in the middle of the knee. And what it does is it stops the 2 bones, the thigh bone and the shin bone, from shifting. Okay. Now inside the knee, you have lining on the end of the bone. That's that cartilage that you don't want to wear out. Because again, wear that out. It's like wearing the tread out on your tires. That's arthritis, which happens to our older athletes. And then the little pad between the bones called the meniscus, which is a little cushion. Purpose of the meniscus is to protect that lining. So if somebody says, hey, I've torn a piece of cartilage in my knee, they mean that. Someone says, I've worn the cartilage out my knee, they mean this. But the ACL is the thing that gives the knee stability. And that's the one thing that everybody is always afraid that might happen to them. And unfortunately, it's a relatively common injury, and there's some significant consequences if that happens.
Yep. Thank you so much. And thanks for having that model to share with us. That was really helpful. Can you talk, are there different types of symptoms that someone would feel? And Dr. Wisbeck talked about pain, swelling for the foot or the ankle. What types of symptoms would someone see if they had a tear in their knee or any other areas of their body from a sports injury?
So the ACL is pretty classic. It's a non-contact deceleration injury where you're running and your knee just buckles and gives out. There's usually acute pain when that happens. You go down and you're not getting back up and continuing to play. Get helped off the sideline. Unfortunately, we've all seen this with either our friends or our family members. And the exam is actually pretty simple. Fortunately, these days we have a lot of athletic trainers that are on field at the games, and they can assist with trying to figure something like this out. They usually help the player, the athlete off the field, and they can give them a good sense of what's happening. If this does happen, you're one of the unfortunate people that do have a catastrophic knee injury. Certainly you're going to want to see a healthcare professional, get in to see one of us in the clinics, come to one of the urgent care centers. And this is something that for the most part is relatively easy in terms of diagnosing. We of course get MRIs these days on everybody that has an injury to confirm things, but an ACL tear is pretty simple to diagnose just based on your physical exam. Some of the other things, the cartilage injuries are more difficult for people to know if they have their injury because it causes pain, but a lot of times you can play through that pain and it can linger for a bit, but the same concept. If you're having pain, if you're having swelling, especially if you're a younger athlete, you need to get this evaluated, because what you don't want to do is continue to play on an injury and then cause further damage down the road and end up with that arthritic knee, which you really want to try to avoid if possible. Yeah.
It's always tough to tell yourself to stop, right? Especially for our athletes. Any advice to someone that wants to try to push through an injury? You just said it could cause arthritis. But what are some of those conversations that you have with athletes as if they have an ACL tear, and it's sometimes a devastating, maybe even career-changing injury? How can someone really push through that? What are some of the things that you talk about with the patients that deal with these types of injuries that can be that catastrophic?
Yeah, I mean, when you have an injury like an ACL, the important thing is you're not alone. There are people to help you. There's the coaches, your fellow players, your family, the physicians. There's so many people, and you should really use those resources to help you. You don't have to go through this all by yourself in a little vacuum. And unfortunately, when you tear your ACL, for the most part, most people will end up with a surgery and a whole rehab. And on Facebook, there's oodles of different groups and support groups that look at that. The groups of people that can talk about their stories and how they went through it, and a lot of success stories, fortunately. In terms of the other things, I always tell people diagnosis. You can't treat something unless you know what's wrong. So if you want to say, well, I have a knee problem, I have knee pain, I'm just going to do this because this is what Joey, my friend, told me to do. No, figure it out, know what you're dealing with, get the diagnosis, see one of us. Usually it's a very easy thing to explain, and we can send you down the right path for treatment. So figure out what it is first. Don't try to push through stuff. It's okay. Get the help you need, and then move on, and then you'll have a better success rate.
That is great advice. Thank you. Let's talk about the treatment options. You mentioned surgery. Are there any other types of treatment options for the knee that you would utilize in a diagnosis? Especially an ACL tear. I don't know if there is anything other than surgery. Can you explain that?
Well, in terms of the ACL, the problem is when you tear your ACL, if you continue to run, turn, cut, pivot, live an active lifestyle, there is a good chance that you will have recurrent episodes where your knee is not supporting you. So for some athletes, that's a problem because every time they go out and play, they can't have their knee re-injure and get knocked out again. But more importantly is what we want to do is we want to protect the long-term health of the athlete or the individual. Now, unfortunately, when you tear your ACL, whether you get it rebuilt or not, the chances you're going to end up with arthritis later on in life is pretty high, up to 50+%. So it's an issue, and we're doing a lot of research on various different things, repairs, using scaffolds, a lot of different ways to maybe change how we fix ACLs. But for the most part, for your young athlete, and even your middle-aged to younger person, ACL reconstruction or rebuilding that ACL is going to be the way to go. You don't have to have your ACL rebuilt. The reason we do it is to try to minimize recurrent cartilage problems. Remember those little pads I showed you that will tear if you continue to have your knee buckle. So not everybody that tears their ACL needs to have a surgery, but I would say the vast majority of people do opt to have that surgery for the reasons that we said. One, to allow them to continue to be active, but also to try to minimize some of that additional injury that'll happen if you allow your knee to continue to buckle. Other things, cartilage tears, maybe a small meniscus tear, especially as we're getting older. A lot of times we treat these non-surgically. So just because you're coming in to see someone like me does not mean that you're going to say, yes, you have to have a surgery. There are tons of different diagnoses. And actually, the vast majority are treated non-surgically. So physical therapy and various other modalities. So again, know your diagnosis. Yeah, the ACL is the one everybody knows about and talks about, but there's a lot of other injuries that can happen in the knee, and most of them can be treated pretty successfully.
Thank you very much. What about prevention? Is there anything for our viewers to keep in mind to prevent any of those types of injuries that you mentioned?
No, absolutely. And there's been a lot of research and work going into how do we prevent, how do we lower these tear rates, because obviously much better to prevent it in the first place to worry about the different ways of fixing it. And if you meet with any of the therapists in town, we have plenty through MedStar, and even go online and look at some of the programs out there. There have been developed a lot of different ways to keep yourself fit, strong core strengthening, the way you land and jump. There's even some templates out there to show that when you jump and land, if you were to keep your feet under your body instead of letting your knees kind of buckle in almost like a grasshopper would look, you can decrease the rate of ACL tears. So there's a lot of literature out there and a lot of different programs that will help some of these younger athletes try to improve their form, strengthen their core. Don't overplay. Don't go out there if you're not appropriately rested, to try to minimize some of these injuries. Because unfortunately, once it happens, there's not a whole lot of choices.
Okay, well, thank you so much. Really appreciate you explaining other injuries that could happen to an athlete, talking through the anatomy, the symptoms, and treatment prevention. Just want to remind our viewers that we are taking your questions. So if you have any for our experts, Dr. Levine or Dr. Wisbeck, please ask them in the comments. We have, if you didn't catch us at the very beginning, we've talked about the differences between grass versus turf fields, the effects that they can potentially have on sports injuries, foot and ankle injuries, and then other injuries, including the knee. So we do have a question that came in going back to our conversation about grass versus turf. This question was from Andrew. Andrew, thank you for asking this question. So we talked about turf, and also when we were talking about grass, we were talking about how with normal grass, sometimes there could be potholes and divots that can create an injury, which we don't see in turf, but there can be some wear and tear on turf. So Andrew asks, how often should that turf be replaced to help avoid those injuries? Is there something that some type of regular maintenance that needs to be done to help prevent those injuries? Dr. Levine, do you want to take that one?
Sure. So absolutely. Yeah, it's a great question. And again, when we're looking at some of these studies to say, does it matter? You're looking at NFL and you're looking at Division I NCAA athletes. These fields are maintained and they are always turned over. They always have new turf, and this just does not translate to the rest of the population. Because let's face it, your small town may have a great turf field, but doesn't have the budget to replace this over and over as the technology improves. I think if you go to the turf online to any of these turf manufacturers, you'll see the exact list of the maintenance and how long they're supposed to last and what they're supposed to do. And I believe in some of these fields, they even go out there and test it. They test how springy it is, if that's such a word. But they have various different things to say, what is this turf doing? How much is it used? How long is it going to last? So I don't know the exact numbers, but I know that they're out there because I've seen those lists. I just didn't memorize them. But it's going to have multiple factors. And it's a great question. But what it comes down to, like a lot of things, it's about money, and it's hard to replace these fields if you just don't have the budget to do it. It's also hard to maintain a grass field if you don't have the groundskeepers and the people that run the sprinklers, and depending on what part of the country you're in. So they both have expenses. They're definitely advantages and disadvantages, but the bottom line is absolutely there are recommendations from these companies on how to maintain their fields and when they do have a lifespan.
Thank you very much for that, Dr. Levine. Let's go back to our conversation that we were having about surgery. Dr. Wisbeck, wanted to ask you if there is a serious injury to the foot or the ankle and surgery is the treatment that is decided upon between the physician and the patient. What is the long-term outlook for those patients? When can they go back on the field? What are the lifestyle changes that they would need to make post-surgery?
Well, it's a great question. And again, it gets back to diagnosis. So if you have an extra articular, meaning outside of the joint ankle fracture that requires a surgery, you're getting walking on it within maybe 4 weeks. You're out of a boot maybe at 6 weeks, and then you're rehabbing to get back to playing. If you have a more involved fracture, intra-articular, meaning it goes into the joint, extends into the joint, or multiple bones were fractured, but the inside of the ankle, outside the ankle, back of the ankle, high ankle sprain, that's a bigger injury. And it's a bigger recovery and a longer recovery. When it's not based on the size of the injury either. The big toe, plantar plate injury, which is a ligament on the bottom of your great toe, that has ended the careers of many very famous NFL players, even with surgery to fix it. So, you ask, what is the outcome? Where are they going to be? My goal every time I treat somebody or take someone to the operating room is to get them back to the day before the injury. Many times we do that, but sometimes we don't. And it has nothing to do with necessarily the skill of the surgery or the diagnosis or maybe even who did the surgery or what happened. It's the injury itself. We all know that a traumatized something may never get back to where it was the day before, but the idea behind the surgery is to do what you need to do to give you the best chance at getting what you had the day before that injury. And luckily we're able to do that for most of our patients, but sometimes we can't. But that's discussed. That's one of the things that I feel maybe sets me off a little bit from other folks, is I am exceptionally realistic about what we're doing with the expectations and where we're going to go. And I think the patient will have a very clear understanding of what the hopes are and the expectations are with the surgery. And if we exceed that, everybody's happy. But in the end, you're going to get a very honest opinion about where this is going to end up. We've been fortunate enough that, Achilles tendon injuries, there's literature and research that's from the NFL that says maybe 20 to 25% of people don't get back to playing again. Yet I've got patients that participated in their age group Olympics that won gold medals after an Achilles tendon surgery that was a high stress event for the Achilles tendon. So does that make me better than the guys that did the surgeries for the NFL? I'd like to say yes, but sometimes it just doesn't work out to get back to where you were. But we do everything in our power to make sure that we give you the best chance of having that happen.
Great, thank you so much. Dr. Levine, what about from your perspective? What is the long-term outcome for your surgical patients?
Yeah, so again, as Dr. Wisbeck says, it depends on the diagnosis. With the ACLs, unfortunately, when you're a young athlete, you tear your ACL, the chances you're going to have another ACL tear, either the same knee or the other knee, can be quite high. In our teenage, our female adolescent athletes, that number can be up to 30%. So there's some serious conversations that need to happen with the family, with the athlete, to say, okay, after you're done with all of this rehab and you're rebuilt, what should you be doing? Are you willing to take that risk? Should you take the risk? And what are the preventative measures? Not everybody that has a surgery gets back to their pre-injury level of play. A lot of people desire not to go back to that level and would check the box saying, I never made it back. Also, as you get older and you're a scholastic athlete, if you tear your knee in high school and you didn't play in college, you might not have been playing in college anyway. So did you make it back to where you were? Not really, but that might not have been what would have happened if you didn't have the injury. So kind of complex. I think that it has to be taken on an individual basis. I think today's day and age, most athletes that tear their ACL do plan on returning to sport, and certainly a lot of them do. And you can see that just by watching TV. You see athletes at the very high level tear their ACL and they're back the next year and breaking records. So it can happen. But if you look at everybody across the board, by no means is everybody making it back to that level.
Thank you. And we have a related question from our viewers. This is from Nicole. Thank you, Nicole, for your question. She's asking, how about bracing post ACL tear or surgery?
Yeah, so bracing is also a controversial topic. If you look at all the studies going back to a non-contact sport, using a brace has not really panned out in a lot of studies to show a decrease in the re-tear rates. There are some studies, I know there was one work comp study looking at skiers and Vail. Probably not a lot of those people, but in that population, it did show a decreased re-tear rate. So I think it's up to the individual if they feel that it gives them support and they're more confident with it, perhaps using it for that first year or year and a half back. Certain sports, it's not an option. If you're a rugby player, if you're a wrestler, certain sports, you're just not allowed to wear it. It's against the rules. Soccer players, they typically do not wear it because it's very hard to field the ball off of a brace. It bounces in all directions. So it can be somewhat sport specific, also even position specific in terms of, say, a football player, a speed guy, a defensive back is less likely to want to wear it as opposed to a lineman that might wear a brace just preventatively. So I think the answer is I am all for wearing a brace, especially for that first year back if you feel it's giving you increased confidence. But unfortunately, I can't say that all the literature is panning out in terms of that really being preventative in terms of that re-injury rate.
Thank you very much. And thank you, Nicole, for your question. Dr. Levine, I understand that you're part of a clinical trial to advance the treatment of ACL injuries. Can you tell us a little bit about that?
Yes, absolutely. So if you remember, I said that unfortunately, 50+% of people that tear their ACL, whether they have it rebuilt or not, end up with an arthritic knee. And if you're tearing your ACL as a teenager and you're becoming arthritic by the time you're in your 30s or 40s, it's a big problem. So if we go back and we look at the success rates of ACL reconstructions in terms of getting back out there and playing sports, we're not that bad. But if you look at success as preserving the health of that knee long term, we're not really that good at taking care of people with ACL tears. So there's a lot of research and literature work on how do you rebuild an ACL, get your own ACL to regrow. And if you think of, if anybody ever had an injury to your MCL, the ligament on the side, it can regrow because there's blood. Where there's blood, there's oxygen, and your body is pretty amazing in healing things. And inside the knee, the ACL has no ability to regrow because the knee is filled with some fluid that blocks that healing process. So we're involved at MedStar in a phase called a Bear 3 trial, where we're now putting this out throughout the country, looking at taking a bovine scaffold, it's collagen, and putting it inside the knee and sewing the remainder of the ACL after your injury into that scaffold and allowing a new ACL to regrow. It's really exciting. There's been some great results on the early stuff that was done out of Boston Children's. And now that it's going into what we call BEAR, Bridge Enhanced ACL Restoration, it's going throughout the country. We were the first center in the country to start doing it. And myself and some of my partners are involved in doing the clinical trials. And thus far, it's gone pretty well, and we're really excited about it. But I do think moving forward, a repair or restoration may be hopefully the holy grail on preventing these long-term issues that happen with people that have these injuries.
That's very exciting. How do people enroll in the clinical trial?
They can either contact my office, or there is an email through MedStar. I wrote it down here. It says join research at medstar.net. And it's a site that those emails will get sent out to different study coordinators throughout MedStar doing all types of research. And then they can set you up with the research coordinators that are working each individual study, and then kind of narrow it down to reach someone like me or one of my partners that's doing this study.
Wonderful. Thank you. And we'll post that email address in the comments so people can get back to that. Thank you. That's really helpful. So I just have one more question. Wanted to ask each of you just to, as we close out today's broadcast, what is the one takeaway or a few key takeaways that you want to make sure that our viewers get out of this conversation that we had today about sports injuries? Dr. Wisbeck, why don't I start with you?
Yeah, I think the key thing is don't ignore pain. Don't, if it's something that's not just a few hours or a day or two, and even if it came out of nowhere, get it evaluated, see what's going on. You may be preventing something bigger from happening. Get seen by somebody who has familiarity with what you do. And getting in to see a doc that manages athletes is a big deal. It's a difference. It's understanding your schedule. It's understanding the process. It's understanding returning to sports. For the college folks, it's understanding medical red shirts versus taking a year off versus years of eligibility. For the high school students, it's understanding the recruitment processes for college athletes and the schedules and making sure you're able to manage things and getting people back to where they need to be at the time they need to be there. And so just make sure you're not making things worse by ignoring something that could easily be managed. And doing that at a place like us, MedStar, that has a ton of people that are used to managing athletes, athletic injuries. We have a whole sports department. We have non-operative sports guys. We have sports medicine orthopedic surgeons. We have guys like me who don't have sports in front of me, but I'm an orthopedic foot and ankle guy that gets a lot of referrals from the sports guys and manages tons of athletes. So we have lots of people that can help and get it figured out before it becomes something that shuts you down for a long period of time.
That is great advice. Dr. Levine, what is your takeaway for our viewers?
Yeah, absolutely. I mean, look, sports are an important part of life. Fitness is an important part of life. And if you're doing these things like most people are, there's a good chance that you're going to unfortunately have some type of injury. And the key is diagnosis, figure it out, use your resources, use the athletic trainers, use people like me that are at the sidelines. When I see somebody that goes down with a foot or ankle injury, I mean, I'm sending them to Dr. Wisbeck because this is his expertise. This is what he does. So, get to the right people, get to the experts, and let them tell you what the deal is, and they'll tell you the best way to take care of it, because you can't put your head in the sand. If you have an issue, address it, figure out what it is, and move on, and then you're going to have your best result.
Love that advice. Thank you so much. Well, that wraps up our broadcast. Thank you, Dr. Levine and Dr. Wisbeck, for joining us today. I know you're very busy guys, and we appreciate the time that you spent today educating our viewers. To all of our viewers, thank you for joining us as well. To schedule an evaluation with Dr. Levine or Dr. Wisbeck, you can call 877-34-ORTHO. We're also going to put that in the comments so you can easily find it. And thank you for joining us. We really appreciate it. You can watch the replay on our page at any time. Dr. Levine, Dr. Wisbeck, thanks again.
You're welcome.
Thank you for
Karen.
having us. Yep.